Welcome all. We will discuss talk article today, insulin pumps in pregnancy. Okay, CSII, that is continuous subcutaneous insulin infusion. Okay, so diabetes is one of the common condition which is seen during the pregnancy, and few of the patients may be on these pumps which these pumps patient may be using before the pregnancy also. Sometimes the treating physician may start during the pregnancy also. So what about these pumps during the pregnancy? That is what is the discussion in this particular talk article. So what does this pump do? It uses rapid acting insulin only. So one thing you remember that with the pump only rapidly acting insulin can be given. Okay, but we can give both, that is the basal rate as well as bolus doses also. Basal rate in the sense the continuous background insulin is going on as per the requirement, and bolus dose when there is a meal time, that time you need to give the bolus dose. So this all is possible, means basal rate insulin infusion is also possible, plus bolus dose is also possible with this pump. So this is going to be an advantage. Okay. Now, what are the types of devices? There will be one is a conventional pump that has got tubing and cannula, and another is a patch pump, which is actually a tubeless pump. So these are the two types of devices. Now, how the pump works basically? The pump has got a reservoir, then there is a tubing and cannula. This pump will give the insulin at a basal rate also. It will also give at a bolus dose also whenever there is a need, and there is a programming for this. So reservoir will hold the rapid acting insulin, and we can give only the rapid acting insulin via these pumps. Okay. Then there is a tubing or cannula that deliver the insulin subcutaneously. The basal rate is a continuous programmable infusion. Basal rate is a continuous programmable infusion, while bolus is the around the time of meal the dose is to be given. Sometimes the correction is also required depending upon the exercise, depending upon the meal type, the correction is also required. And it is a programming, that is the carb counting, correction factor, basal patterns, that all needs to be programmed. So this actually requires well education of the patient. That is the most important, because patient should be able to calculate the carbohydrate in the diet in that particular meal. So patient education is important. Not only that, the correction factor, because of certain maybe change in the type of diet, and the carbohydrate composition will change, or maybe because of the exercise, the correction factor is required, so that the patient should be able to understand, and the basal pattern. Okay, so this is all is included into the program. Okay, so the what is the problem? No long acting insulin can be given. So decay risk if the patient, if the pump stops, because we can give only the rapid acting insulin, the long acting insulin. So there is no buffer which is available. So once this pump stops functioning, immediately the insulin is stopped. Okay, and there is a high risk for the development of the diabetic ketoacidosis if the pump becomes malfunction. Okay, so indications in pregnancy. So what does the NICE say about these particular pumps? So continuous subcutaneous insulin infusion should be offered in patients with suboptimal glycemic control despite optimized multi-dose injections or the insulin, or those with disabling hypoglycemia. So routinely it is not indicated. So what does the NICE says? Routinely not indicated, but in those patients who have got a repeated hypoglycemia, or in spite of multi-dose injectables, the glycemic control is not appropriate or is suboptimal, then these patients can be given this type of CSII. Okay, so continuous subcutaneous insulin infusion pump can be given to this category of patient. Which category? One is a poor glycemic control on MDI, or there is a disabling hypoglycemia. Okay, it is also useful in patients having hyperemesis gravidarum, dawn phenomena, very low insulin requirements. We know what happens in dawn phenomena. In dawn phenomena, it is the early morning, there is a hyperglycemia, and this hyperglycemia is mainly because of the increased levels of the anti-insulin hormones. Okay, so there is a, in these patients there is, and there is a difference between the Somage phenomena and the dawn phenomena. Okay, so what happens in Somage phenomena? There is a early morning hypoglycemia followed by the hyperglycemia. Here in dawn phenomena, you get the hyperglycemia, and this hyperglycemia, generally the checking is done at around 3 o'clock in the morning. You need to check this around 3 o'clock. Okay, so advantages and disadvantages of these pumps. what are the advantages? One, better glycemic flexibility. There is a decreased hypoglycemic episodes, adjustable basal rates, no multiple injections are required, and useful in erratic intake. Okay, so even if the intake is improper, if the patient is able to calculate the carb, they can adjust the dose. Then disadvantage, it is expensive, requires education. There is a high risk of diabetic ketoacidosis if it fails. Site infection risk is there, and it is always a compliance dependent. Okay. Now, what does the evidence say about this? If it is used continuously, HbA1c, there is a slight improvement. Hypoglycemic episodes, definitely they are reduced, but the perinatal outcome, there is no clear superiority as compared to the multi-dose injections of insulin. Okay, so perinatal outcome is same with CSSI as well as MDI also. And as far as safety is concerned, safety is same. Okay, that is why the NICE does not recommend it routinely, only in those patients who have got a repeated hypoglycemic episodes and there is a suboptimal control with MDI. Then you can go for CSII. Okay, so CSI is not a gold standard because no strong RCT, there is a superiority over the MDI. Okay. So practically, it is actually the team MDT care involving the diabetologist, obstetrician, diabetic nurse, midwife, and dietitian. So the structured education, as I already mentioned, the structured education is the most important thing. This is the DAFNE program, that is a dose adjustment for normal eating. So the patient should be able to understand this dose adjustment for the normal eating. This is mandatory if the patient is using CSII. Okay. Then start pump at least 3 months before conception. So the target should be, this is same as NICE guideline. HbA1c should be below 48 millimoles per mole. That is 6.5% HbA1c should be the target, or less than 48 millimole. Okay. And avoid pregnancy if the HbA1c is more than 86 millimole or 10%. Okay, so please remember these millimoles also, because most of the time in exams they use these values. This may not be given. Okay, so HbA1c less than 48 is the desired target, and pregnancy is to be avoided if it is more than 86 millimoles per liter. Okay, then carbohydrate counting is important, essential for pump use. Generally, 1 unit of insulin will take care of 10 grams of carbohydrate. Okay, however, it depends upon the stage of the pregnancy. Okay, what happens in the early pregnancy? The dose of the insulin required is less because there is an increase in the sensitivity to the insulin. But as the pregnancy advances, there is a insulin resistance also, and the anti-insulin hormones will also come. And the 1 unit will not take care of the 10 grams of carb. 1 unit may be able to control only 3 grams of carbohydrates. Okay, that is why there is a frequent adjustment of the dose is required. Okay, so how is this insulin requirement during the pregnancy? So insulin requirement falls in early pregnancy due to increased sensitivity, then rise progressively after 16 weeks due to the placental hormones, that is placental hormone induced insulin resistance, with the marked increase in both basal as well as bolus insulin in late pregnancy. So what happens in the first trimester in early pregnancy? There is a decrease in the basal insulin. Okay, and this is mainly because of the increased insulin sensitivity. So requirement of the basal insulin is reduced because of the increased insulin sensitivity. But as the pregnancy advances after 16 weeks of gestation, it is mainly the basal insulin, around 50% basal insulin is required. This is mainly because of the insulin resistance. But in late pregnancy, the bolus need is also increased, and this is mainly because of the placental hormones. Okay, so early pregnancy, what we mentioned, the carb ratio, which was 1:10, but in latter pregnancy, 1 unit will be able to take care of 3 to 4 grams of carb only. Okay, this is also you should be able to understand. So this is, if you have understood this, then you will understand the further complications. Okay, so pump uses only rapid insulin. So if any interruption in the pump function, there is a rapid risk of diabetic ketoacidosis. Now, if the patient comes in labor, what to do? Okay, if the patient is using the pump, they can give scenario on this. So if the patient is using continuous subcutaneous infusion of insulin, and if the patient is it is well controlled, if the team is experienced and patient is able to manage, it is always better to continue the pump. Okay, so we will continue the pump if it is a well controlled glycemia, team is experienced, and the patient is able to manage. Otherwise, switch to IV insulin infusion. Okay, that is our traditional management. We start with IV infusion. Okay, So if these criteria are not there, then we will start with the IV insulin infusion. But in a well-trained setup, go ahead with the management with the insulin, because the management is easy. Okay, and generally the patients are well trained. Okay, so glucose management, frequent monitoring is required. Use lowest effective basal rate and good control, and will lead to the decreased neonatal hypoglycemia. Okay. Now, what about the postpartum management? What happens in the postpartum period regarding the insulin requirement? There is an immediate fall after the placental delivery. So we have to come back to the pre-pregnancy doses. So breastfeeding effect is there. After delivery, insulin requirement will fall rapidly, and breastfeeding further lowers the maternal glucose levels, increasing the risk of hypoglycemia. Basically, what happens? The lactation itself induces this uses the glucose. Okay, so lactation is a glucose consuming process. So milk production uses the maternal glucose as the main substrate. So around 50 grams of glucose per day is utilized only for the milk synthesis. Okay, so generally there is a reduction in the glucose level, and patient may need snacks or the basal adjustment. Okay, so accordingly the dose should be adjusted, or the patient should take the snacks. Okay, special situation like hyperemesis gravidum, pump is advantageous because the flexible dosing is possible, and there is a erratic intake adaptation, because as per the intake the patient can adjust. Then hospital admission, do not stop pump if it is working, involve diabetes team. And there are further advances in the pumps also. One is a continuous glucose monitoring. Okay, so what happens? There is a continuously glucose being monitored. Every 1 to 5 minutes, the glucose is being monitored, and that will help to reduce the incidence of the hypoglycemia. And there is a sensor augmented pumps. What this sensor augmented pump will do? You have a CGM. Continuously glucose monitoring is there, and this sensor augmented pump will notice that if the glucose level is going down, then they will automatically suspend the insulin if the glucose is falling. So this is actually, these are the current advances. So with low glucose, they will suspend the insulin. Then future goal is the closed loop system. It is nothing but the artificial pancreas. So it is the same advancement in the same sensor augmented. So a fully automated system will be there, where there is a continuous glucose monitoring. Then the pump will deliver, and there is an algorithm depending upon the inputs which are received from the sensor, the pump will work. Okay, so that will work together to adjust the insulin without patient input. So normally what happens with these pumps, the patient input, patient education, what we discuss. But if it is a closed loop system, where the artificial, it will work like an artificial pancreas only on the continuous glucose monitoring. There is will be an algorithm, and the pump will function accordingly from the sensory input from this. Okay, so these are the future goal. What does the NICE says about the continuous glucose monitoring? It should not be used routinely. It can be considered if there is a severe hypoglycemia or unstable glucose. Okay. So from examination point of view, we should remember that continuous subcutaneous insulin infusion uses rapid acting insulin only. If there is a pump failure, there is a chance of rapid diabetic ketoacidosis. There is no strong evidence superiority over the multiple doses of insulin. It is best suited for the patients who have repeated hypoglycemia, poor control, and hyperemesis. Basal requirement is decreased in early pregnancy, but as the pregnancy advances, it is increased. Postpartum insulin requirement is decreased immediately, and it can continue in labor if safe. So pump can be continued. Okay. So certain things you should remember. The pump is it best for all? No, it is best only for selected cases. Safer than MDI? Is it safer than? The outcomes are similar in both cases. That is what is the fact. Okay. So can we give the long acting insulin? No, we can give only the rapid acting insulin with this. Then is there is advantage of decay? No, there is a high risk for the decay if the pump becomes malfunctioning. Okay, so must stop in labor. No, we can continue this pump during the labor also. These are the things which you should remember about the infusion, because you may get some scenario about it. Okay, so doctor, we have few questions. Please go through the questions and answer this.
Yes. A 28-year-old woman with type 1 diabetes on insulin pump presents at 30 weeks with vomiting. Her pump tubing is found to be kinked for several hours. She is drowsy with ketonuria. What is the most important underlying reason for her rapid deterioration? A. Increased insulin resistance in late pregnancy. B. Use of rapidly acting insulin only in pump. C. Dehydration due to vomiting. D. Increased basal insulin requirement. E. Failure of carbohydrate counting.
Doctor, what is the question? Her pump tubing is found to be kinked for several hours. So what does this mean? Why she is vomiting?
Is having diabetic ketoacidosis
Why there is a ketoacidosis in here?
because there's no proper
Because
uh,
the pump is
pump is
malfunctioning.
kinked.
Okay. So what could be the cause here for vomiting? It is a diabetic ketoacidosis. Why there is diabetic ketoacidosis in this patient? Because pump is using only rapid acting insulin. No, there is no
Yes.
buffer which is available. Okay. That's use of rapid acting insulin only.
Oh,
That is the we can give only. Otherwise, if there would have been other insulin also, if you could have given, then that is not possible with pump. No, CSII
okay.
delivers only rapid acting insulin, so no long acting insulin, so no safety buffer. So pump interruption, there is a rapid decay chance. Okay,
Yes, sir.
next.
A clinician is counseling a pregnant woman with type 1 diabetes about insulin pump therapy. Which statement is most accurate regarding evidence in pregnancy? CSII significantly reduces perinatal mortality compared to MDI. CSII is superior to MDI in all pregnancy outcome. CSII has no role in pregnancy. CSII improves HbA1c but shows no clear superiority in outcome. CSII is contraindicated in pregnancy. This D, it shows no superiority in outcome.
Which one?
D,
D. CSI improves HbA1c but shows no clear superiority in
clear.
outcomes. HbA1c, yes, definitely improved. Okay, so evidence shows that HbA1c is reduced, hypoglycemic episodes are reduced, but no clear superiority versus MDI in pregnancy outcomes. Okay, next.
A 32-year-old woman with type 1 diabetes on insulin pump is in established labor. She is alert and has good glycemic control antenatally. Staff are familiar with pump use. What is the most appropriate management? A. Stop the pump, start IV infusion for all women. B. Continue pump with close monitoring. C. Stop the pump and give subcutaneous insulin. D. Switch to oral hypoglycemics. E. Disconnect the pump during labor. It is B. To continue pump with close monitoring.
Yes, yes. So it can be continued. So you need a well-trained staff, good diabetes team, and generally the patients are already trained it. Okay, it helps a lot. So intrapartum management, pump can be continued if there is a good control, patient competent, and staff experience. Okay, otherwise go for IV insulin. Next.
A pregnant woman using CSII notices frequent hypoglycemia at 10 weeks of gestation. What is the most likely physiological explanation? A. Increased placental hormones. B. Increased insulin resistance. C. Increased insulin sensitivity. D. Reduced renal glucose excretion. E. Increased glucagon secretion. It is C. Increased insulin sensitivity during first
Yes.
time.
Yeah, that is why then she will require a dose adjustment here. Okay. So increased insulin sensitivity, physiology of insulin requirement, early pregnancy, there is increased sensitivity leads to decreased insulin requirement and increased hypoglycemia risk. Okay, next.
A woman with type 1 diabetes on CSI delivers vaginally. What is the most appropriate insulin management immediately after placental delivery? A. Increase the insulin dose. B. Maintain pregnancy dose. C. Stop insulin completely. D. Reduce to pre-pregnancy dose. E. Switch to long-acting insulin only. This D. Reduce to pre-pregnancy dose.
Yeah, we'll go
Maybe.
back to the pre-pregnancy dose here. Okay. So postpartum placenta is removed. There is a decrease insulin resistance abruptly. So insulin needs will be dropping immediately. Next.
A pregnant woman with type 1 diabetes is on MDI. She has good HbA1c but frequent severe hypoglycemic episodes. What is the most appropriate next step? A. Continue MDI and unchanged. B. Reduce insulin dose only. C. Start insulin pump therapy. D. Start oral hypoglycemics. E. Stop insulin. It is a C to start pump therapy, insulin pump
Yes,
therapy.
this is an indication. Okay, So clinical indication, disabling hypoglycemia, CSII is recommended. So same, the take-home message is the pump will give only rapid insulin. Okay, that is why there is a diabetic ketoacidosis risk. Evidence, what does the evidence say? No clear superiority over MDI. Labor, it can be continued. The pump is safe. Okay. Early pregnancy, there is an increase, there is a decrease insulin because of the sensitivity, increased sensitivity to the insulin. Postpartum, insulin requirement is reduced. Okay, and key indication is a hypoglycemia for this starting. Okay, so that finishes this talk article. Thank you.